Hi, as with any aspect of hand surgery, understanding the anatomy is paramount. Flexor tendon surgery is no different. The flexor tendon anatomy must be understood in many ways. For instance, the structural anatomy, the functional anatomy, and the surgical anatomy, apart from the anatomy of the vascularity, the anatomy of the Pulley system, and the anatomy of the flexor tendon injury zones and why they are divided into zones. I believe that when you want to understand a concept completely, you have to write it down or draw it. In keeping with this principle, I would be drawing a few parts of the anatomy for better understanding and comprehending the function. We shall be discussing the flexor tendon anatomy under the following headings: gross anatomy, retinacular system, blood supply to the tendons, and the zones of flexor tendon injury and their anatomical basis. Under the discussion of the gross anatomy, we shall be discussing the origin, course, and insertion along with the nerve supply of the flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, and the lumbricals, which are very closely associated with the flexor tendons. The flexor digitorum superficialis, or the FDS, originates for the middle and ring fingers from the medial epicondyle, the proximal ulna and the radius, while for the ring and little fingers they originate mainly from the common flexor origin at the medial epicondyle. The insertion is to the middle third of the middle phalanx. The nerve supply to this group of muscles is from the main trunk of the median nerve, the branches which are given off just distal to the elbow. These muscles have tendinous insertions which are individual and can be moved individually. The flexor digitorum profundus, or the FDP, originates from the anterior and proximal medial 2/3 of the ulna. The insertion is to the base of the volar aspect of terminal phalanx of the fingers. The FDP of the index finger has some amount of individual function, but the tendons of the other three FDP, that is the middle, ring and little finger, are interconnected and cannot act individually. The nerve supply to the flexor digitorum profundus is different for the index and middle fingers when it is supplied by the anterior interosseous nerve, which is a branch of the median nerve. The nerve supply to the ring and little finger flexor digitorum profundus is by the branches from the ulnar nerve. The flexor pollicis longus muscle originates from the oblique line on the flexor surface of the radius. The insertion is to the palmar base of the distal phalanx of the thumb. The nerve supply is from a branch of the anterior interosseous nerve. The flexor pollicis longus arises from the ulnar side of the unipennate muscle belly. This is very interesting because when trying to identify the muscle within the flexor mass, if you identify a unipennate muscle coming from the radial side, it is definitely the flexor pollicis longus. After it enters the hand through the carpal tunnel, the flexor pollicis longus courses between the opponent's pollicis and the oblique head of the adductor pollicis before it gets inserted into the base of the terminal phalanx. There are 4 lumbrical muscles in each hand. They originate from the radial side of the flexor digitorum profundus for the index and mid fingers, and for the ring and little fingers they originate from both the radial and ulnar sides of the corresponding flexor digitorum profundus. So, the first and second lumbricals are unipennate and the third and fourth lumbricals are bipennate. The insertion of these lumbricals is into the radial side lateral band of the extensor expansion. So this is a very unique muscle in that it originates from a muscle tendon and is inserted into another tendon. The first and second lumbricals are supplied by branches from the median nerve, and the third and fourth lumbricals are supplied by the deep branch of the ulnar nerve. As far as the flexor digitorum superficialis and flexor digitorum profundus tendons are concerned, in the distal arm, the flexor digitorum superficialis tendons lie anterior to the flexor digitorum profundus and flexor pollicis longus tendons. The FPL tendon along with the FDP tendons forms a sheet upon which the FDS tendons lie. Among the flexor digitorum superficialis tendons, the middle and ring finger superficialis tendons lie volar to those of the index and little fingers as shown here. The arrangement of the superficialis tendons is just like is shown in this hand. The middle and ring fingers lying volar to the index and little fingers at this level. Then the FDS and FDP tendons to all the fingers enter the palm through the carpal tunnel along with the flexor pollicis longus and the median nerve. Here again, the relationship of the FDS tendons and the FDP tendons continues as in the distal forearm. That is, the FDS of the middle and ring fingers superficial most, then the FDS of the index and little fingers, and most deep are the 4 tendons of the FDP of the fingers. Once the tendons enter the palm, the superficialis and profundus tendons pair off to their respective digits with the superficialis tendons still volar at the level of the metacarpophalangeal joints, which roughly correlates with the distal palmar crease on the hand. The flexor tendons begin their course through the synovium-lined fibro-osseous tunnel known as the digital flexor sheath. When the FDS and FDP tendons enter the flexor digital sheath, the flexor digitorum superficialis is still superficial. When the FDS reaches the distal portion of the A1 pulley, a split begins in the tendon. The split deepens by the time the flexor digitorum superficialis reaches the proximal 2/3 of the proximal phalanx. It now splits into 2 slips. The 2 slips run on either side of the flexor digitorum profundus tendon, with the volar side now facing laterally. Then the 2 slips again reunite on the dorsal side of the flexor digitorum profundus, with the lateral sides now facing toward the dorsal side. The 2 slips join together and this forms the Campers Chiasma. There is a decussation of fibers at this level. Then this chiasma splits into 2 slips again, which gain insertion into the base of the middle phalanx. To understand this anatomy better, let us see now the relationship between the FDS and the FDP at the level of the Campers Chiasma. This shows the split in the flexor digitorum superficialis, the FDP going through the split and becoming superficial, the formation of the Campers Chiasma, which is dorsal to the flexor digitorum profundus tendon, and the vincular arrangement at the Campers Chiasma, through which the vinculum longus to the flexor digitorum profundus and the vinculum brevis to the flexor digitorum superficialis are attached. The chiasma provides a pathway for the FDP tendon to proceed distally. It increases the stability and balance of the proximal interphalangeal joint and prevents hyperextension at this joint. As far as the FDP is concerned, it enters the flexor sheath dorsal to the FDS, travels through the Campers Chiasma and inserts into the proximal portion of the terminal phalanx. Anatomical variations are seen mostly in the flexor pollicis longus in the form of the Ganser's muscle, which is an accessory FPL muscle, and it inserts into the FPL muscle or tendon. The other anomaly that can occur results in the Lindbergh sign, that is, when there is a tendon slip connecting the FPL and the FDP of the index finger. So, flexion at the thumb IP joint produces a concurrent flexion at the index distal interphalangeal joint. Now we shall see the retinacular system that supports the flexor tendons in the hand. There are 3 main components: the transverse carpal ligament, the Palmar fascia and aponeurosis, and the Palmar and digital pulley systems. The transverse carpal ligament is nothing but the flexor retinaculum which spans across the carpus. It is the flexor pulley of the wrist. It is important because when it is divided, the required excursion of the FDP and FDS is increased by 25% and 20% respectively, and the grip strength of the hand and fingers is also weakened. In the palm, the first supporting structure for the flexor tendons is the palmar aponeurosis, which is sometimes called as the A0 pulley. The supporting fibers are in the form of longitudinal fibers and transverse fibers. The pre-tendinous bands that are seen in the palmar aponeurosis form the longitudinal fibers in front or superficial to the flexor tendons. There are transverse fibers in the palmar aponeurosis that also support the flexor tendons. These are either proximal, which are actually deeper and called the fibers of Skoog, or distal, which are more superficial and called the natatory ligament. These fibers also extend to the radial side over the thumb, forming the distal commissural ligament of Grappo and the proximal commissural ligament. The third and most important part of the retinacular system, which supports the flexor tendons, are the palmar and digital pulley systems. This consists of two components, the retinacular component and the membranous component. The retinacular component is derived from the word retinere, which means to hold in Latin. This literally holds the flexor tendon. The membranous component consists of synovial tissue. The retinacular component consists of the flexor tendon sheath. The condensations of the sheath form the flexor pulleys. There are 5 heavier annular pulleys represented by the letter A and 3 filmy cruciform pulleys represented by the letter C. The annular pulleys are named A1 to A5 from proximal to distal, and the cruciform pulleys are C1, C2 and C3 from proximal to distal again. To understand the position of the annular and cruciform pulleys, we shall now draw a diagram. This shows the metacarpal, proximal phalanx, middle phalanx and the terminal phalanx. Over the level of the metacarpophalangeal joint is the first pulley called the first annular pulley A1. The next pulley is over the proximal 2/3 of the proximal phalanx. This is the A2 pulley. Over the proximal interphalangeal joint is the next annular pulley called the A3 pulley, and over the middle of the middle phalanx is the next annular pulley called the A4 pulley, and over the distal interphalangeal joint and base of the terminal phalanx is the A5 pulley. The first cruciform pulley is between A2 and A3 pulleys, and second cruciform pulley is between A3 and A4, and the third cruciform pulley between the A4 and A5 pulleys, and that is the position of the flexor tendons within this sheath. So as we have seen, the A1 pulley is over the metacarpophalangeal joint. It has a length of about 7.9 millimeters. The A2 pulley over the proximal phalanx has an average length of 16.8 millimeters. This is the most important pulley as far as the biomechanics of the tendons are concerned. The A3 pulley over the proximal interphalangeal joint has a length of about 2.8 millimeters, and the A4 pulley over the middle phalanx has a length of 6.7 millimeters, and the A5 pulley over the distal interphalangeal joint has a length of 4.1 millimeters. Both the pulleys over the PIP and the DIP joint are attached to the palmar plates. The annular pulleys are thicker, they are stiffer and keep the tendon close to the bone, and they economize the tendon excursion, whereas the cruciform pulleys are thinner, collapsible, and they provide the accordion effect to allow the digital flexion without deforming the annular pulleys. When we look at the ultrastructure of these pulleys, we find that they have 3 layers. The inner layer secretes the hyaluronic acid and provides for gliding of the tendon. The middle layer is rich in collagen. It provides a strength and resists palmar translation of tendons. And the outer layer is the areolar layer, which is necessary for the nutrition of the pulley. The membranous component of the pulley system consists of visceral and parietal layers, and this allows for gliding of the tendons. This is nourished by synovial fluid. To understand the visceral and parietal layers of the membranous component of the digital pulley system, we shall see a video. First we see the two flexor tendons surrounded by the visceral and the parietal layers, that is the bone underneath, surrounded by the digital sheath, which consists of the pulleys. Within this system, we can see the blood vessels entering through the vincular tissues. This synovial sheath around the flexor tendons extends from just proximal to the A1 pulley to the A5 pulley in the index, middle and ring fingers. On the thumb, it extends proximally up to the distal portion of the wrist, and on the little finger it extends from the A5 pulley distally to the distal forearm proximally. This synovial sac from the little finger encompasses all the other flexor tendons at the level of the carpal tunnel. It is known as the ulnar bursa. The synovial sac from the thumb always stays separate, and it is called the radial bursa. This synovial membrane provides an enclosed synovial fluid environment for tendon nutrition and smooth gliding. This retinacular system is also present in the thumb. We have already seen the membranous component, which extends as the radial bursa. The retinacular component consists of three pulleys: the A1 pulley, the oblique pulley and the A2 pulleys. The A1 pulley is located over the metacarpophalangeal joint of the thumb, the oblique pulley over the proximal phalangeal region and the A2 pulley over the interphalangeal joint. Now we shall consider the blood supply of the tendons. There are three sources of blood supply. One is the musculotendinous junction, second is the bony insertion of the tendons, and the third is the mesenteric vessels. Of these mesenteric vessels, there are two systems supplying the tendons. One is the proximal synovial sheath vessels, and the second, most important, is the vincular system. The flexor digitorum superficialis has two vincula, one vinculum brevis, otherwise called the VBS, and one vinculum longus, the VLS. The FDP similarly has one vinculum brevis, VBP, and one vinculum longus, the VLP. The vinculum brevia are triangular folds, one to the flexor digitorum superficialis connecting to the tendon at the level of the proximal phalanx and PIP joint, and one to the FDP connecting it to the middle phalanx or DIP joint. The Vincula Longa, on the other hand, are more delicate and filiform. There are two usually for the flexor digitorum superficialis, both running parallel to each other at the proximal end of the proximal phalanx, and the flexor digitorum profundus has one vinculum longus, which is supplied at the level of the distal end of the proximal phalanx. The vincular system receives the blood supply from the transverse communicating branches of the digital artery. We shall now see in a simple way how the vincular system is arranged. Now this is the flexor digitorum profundus and this is the flexor digitorum superficialis. From the proximal end of the proximal phalanx, we get the vinculum longus to the flexor digitorum superficialis, and at the level of the proximal interphalangeal joint, we get the triangular fold of vinculum supplying the vinculum brevis of the flexor digitorum superficialis. At the distal portion of the middle phalanx, we get the triangular fold of the vinculum brevis of the profundus, and through the Campers Chiasma, we get the filiform vinculum longus of the flexor digitorum profundus. The source of blood supply to the vincular system are the branches from the digital artery and the communication between the digital arteries. So you will note that the vinculum longus are present at the base of the proximal phalanx and the base of the middle phalanx respectively, and the vinculum brevis are present at the neck of the proximal phalanx and neck of the middle phalanx respectively. Apart from supplying blood to the flexor tendons, the significance of the vincular system is that in flexor tendon injuries, the vincular attachment might lead to errors in diagnosis because there may be some movement. These attachments may prevent tendon retraction after injury, and the level of the removal of flexor digitorum superficialis tendon for transfer must be done to preserve the vincular system, and the placement of sutures should be done on the avascular palmar aspect. This pattern of vascularity of the tendons leaves one zone of relative avascularity for the flexor digitorum superficialis in the middle portion of the proximal phalangeal region, and two zones of relative avascularity for the flexor digitorum profundus just distal to the FDS bifurcation and just distal to the vinculum longus of the profundus. Considering the vincular system of the thumb, 50% have vincula longa at the metacarpophalangeal joint level. When this is absent, the FPL is less vascular and easily retracts when injured. 90% of the thumbs have Vincula Brevia. They are present at the distal third of the proximal phalanx extending onto the palmar plate. The significance is that when the FPL is cut distal to the vinculum brevis, it can still incompletely flex the interphalangeal joint because of the attachment to the palmar plate. Taking into account the anatomy of the flexor tendons, the zones of flexor tendon injury have been classified. According to this Kleinert and Verdan zone 1, it is distal to the flexor digitorum superficialis insertion. Zone 2 is the area from A1 pulley to the flexor digitorum superficialis insertion. Zone 3 extends from the distal end of the carpal tunnel to the beginning of the A1 pulley. The zone 4 injury represents injury to the tendons at the carpal tunnel level, and zone 5 represents the tendon injury proximal to the carpal tunnel. The need for such a classification is because surgically, when there is an injury to the tendons, each zone has got a characteristic. Zone 1 represents injury to one tendon in an osteofacial tunnel. Zone 2 represents two tendons in a tight osteofacial tunnel. Zone 3 represents tendons under the palmar aponeurosis and relatively free. Zone 4 represents 9 tendons in an osteofacial tunnel, and zone 5 represents tendon lying relatively free in the distal forearm. Hence, tendon injury in zone 2 and zone 4, where there are more than one tendon in an osteofacial tunnel, are prone for problems after repair. Zone 1 is further divided into zone 1A, 1B and 1C, and zone 2 has been further divided by Tang into 4 zones, 2A, B, C and D. On the thumb again there are 5 zones, zone 1 being distal to the interphalangeal joint, zone 2 from A1 pulley to the interphalangeal joint, and zone 3 represented by the area of the thenar eminence. Zone 4 and zone 5 are the same as for fingers. Now we can understand why Sterling Bunnell called zone 2 as the no man's land, because we need to be cautious when repairing tendons within this region, which consists of two tendons in a tight osteofacial tunnel. I hope you liked the video. Please click on the following links to see more about different aspects of hand surgery like brachial plexus injuries and local flaps. And do not forget to subscribe to keep connected with the latest in learning hand surgery.